I'm going to say welcome to people who are joining our event this evening. We are still expecting quite a few more people, so we're just going to wait a moment as people come into the room. Okay, I see some words of welcome in the chat, so welcome to everyone. Maybe I'll get started, and we'll just, in the interest of time, I do think we'll have more people join us, but I'll do the introduction and more people can join as they're able. So it's my great pleasure to welcome everyone to the Interprofessional Education Hot Topic Series. My name is Leslie Flynn. I'm the Vice Dean of Education and I chair the Interprofessional Education Committee. We do this monthly Queen's Health Sciences event, and the series is designed to provide a teaching and learning forum for healthcare professionals to think about really important topics that are affecting the healthcare system and our work as healthcare professionals. All of our topics are selected because they are relevant to healthcare professionals from multiple disciplines. Our intent is to meet the definition of interprofessional education, and that's when two or more professionals learn with, from, and about each other to enable effective collaboration and to improve healthcare outcomes. So tonight's topic is important. It's one that's really influencing the way we think about healthcare and the goals of care. It's an important topic that warrants our attention and our time, and so that we are well informed in terms of being able to practice to the best of our ability. So I would like to tell you just a little bit of housekeeping is that in terms of questions, we will be providing you with the opportunity to ask some questions of our speakers throughout the presentation. And I'm going to ask you to use at the bottom of your screen the Q&A function versus the chat, because then we can more easily keep track of the questions that are being provided to our speakers. So with that, it's my pleasure to introduce our guests. We have Valerie Cooper, who's a nurse practitioner at Hospice Palliative Care Program, which is the home and community care support services as part of the Southeast LHIN. Welcome, Valerie. Thank you for joining us. We have Dr. Christopher Parker, who's an associate professor in the Division of Respirology in the Department of Medicine, and also a member of the Departments of Critical Care Medicine and the Department of DBMS, Biomedical and Molecular Sciences. Welcome, Chris. And last but certainly not least, Dr. Danielle Kane. She's an assistant professor and a palliative medicine physician, and that's in the Division of Palliative Medicine in the Department of Medicine. So I'd like to thank our three guests and turn it over to them. We're looking forward to everything you have to tell us tonight. Thank you.
Excellent. Well, thank you very much, Dr. Flynn, for the introduction and for framing the topic tonight in the context of the Interprofessional Educational Series. We're very pleased to be able to present this evening on this important topic. And I'm most pleased to be joined today by my co-presenters, Dr. Kane and Val Cooper. And collectively, I hope we can give you a tour of medical assistance in dying in Canada in terms of where we come and where we're evolving in the future. We very much hope to make this an objective overview. And the reason I'd like to stress this is because this, we recognize, is very sensitive content, and for some it may be more sensitive than others. We very much hope that in our attempts to provide an objective overview of this topic, that this is not perceived as a lack of compassion around it. And I hope we'll also be able to convey to you that all three of us are very passionate about this topic. But at the same time, we do recognize that everybody is going to approach it differently. The reason it's important to speak to this is, believe it or not, medical assistance in dying has been available in Canada now for over 5 years. And this provides a great opportunity for us to step backwards and first of all, understand what medical assistance in dying in Canada is, also to understand what our experience has been so far, and look at how MAiD has evolved in Canada. We can then take a look at where we're at now and look ahead to the future and talk about some future challenges or anticipations of future evolution of this process in Canada as we move ahead. Over the course of the session today, we hope to provide some opportunities to ask some questions as we go through. So certainly we do appreciate your input and comments you may have as well. The first thing we need to do, though, is provide a disclosure. And I think I speak for myself, and I speak for Dr. Kane, and I speak for Val as well. We're all MAiD assessors and providers. And this is perhaps interesting because I think 5 years ago, many people who were giving presentations on this topic may not have been so forthcoming about this. And I think that in and of itself speaks to the evolution of the process in Canada. And I hope we'll also be able to stress to you today that although there's certainly a spectrum of attitudes around medical assistance in dying in Canada, and above all, we hope to stress that this is not for everybody. I think we'll be able to also show you some data that says that most Canadians are certainly supportive of this, even 5 years out. I think we also all feel that it's one of the most important and worthwhile things that we participate in as healthcare providers. And certainly this is experiences that we've all brought to the discussion today. And I certainly speak for myself when I say that of all the things that I do in clinical medicine, I find this to be certainly one of the most rewarding, but at times also one of the most challenging. So this is where we'll put you to work for just a second. Perhaps just taking a big step back and understand how we've gotten to where we are. But let's look at a worldwide view of countries that actually allow assisted death. Anybody have any ideas in terms of which country was the first to actually legalize or decriminalize assisted dying? I was certainly surprised to learn this, and I'll display this as a relatively new vulgar display of knowledge here. But the first country to legalize assisted death was, believe it or not, Colombia, way back in 1997. And since that time, there have been several other countries worldwide, not surprisingly, the ones that we all tend to think of, Netherlands, also Belgium, also Luxembourg, and Switzerland as well. The less than United States, this is not a federal right in the United States, and it's left up to the states to actually determine in which states it's permitted. And last I checked, it's allowed in less than 10 of them. As we know, Canada has allowed medical assistance in dying for over 5 years now. More recently, Australia has joined this group of countries worldwide. And most recently, New Zealand, within the last few weeks, has also passed laws allowing assisted death. It's also important to know that in Austria, Germany, Portugal, Italy, there's also legislation before their constitutional courts that are also looking to assess this. So what we've really seen in the past 25 years is evolution worldwide. But when you look at the total number of countries in the world, I think you get a perspective that countries that allow assisted death are still the minority. Now, what about the history of MAiD in Canada? Let's look at a timeline over the past few decades, and really the modern history of assisted dying in Canada takes us back to the 1990s. In 1993, there was a landmark case involving a patient by the name of Sue Rodriguez, who basically took Canada to court right up to the Supreme Court, fighting for her right for an assisted death. And at that time, the Supreme Court of Canada ruled in a very narrow margin of 5-4 against Ms. Rodriguez, and the case was defeated. Between 1991 and 2010, there were no less than 6 private member bills that were introduced to the House of Commons, and over that period of time, all were defeated. Jumping ahead to 2014, in Quebec, which has always tended to be a little bit ahead of the game when it comes to challenging this particular legislation. In 2014, Quebec passed an act respecting end-of-life care, and this really set the stage for the Supreme Court of Canada to subsequently hear a landmark case in 2015, which was K. Carter versus Canada. And at this time, in contrast to the outcome in 1993, at that time, the Supreme Court ruled in favor of Ms. Carter and the other appellants, and the existing laws that prohibited assisted death were ruled unconstitutional. The federal government was actually given until 2016 to pass assisted dying laws. But even before they did that, in February of 2016, the first case of assisted death was reported in BC. And interestingly, this particular case was undertaken by a group of physicians who are all in the room and had all agreed that they would equally be held culpable and liable for that, figuring that there is safety in numbers. Remembering that this is in a period of illegal status around these laws, where there weren't necessary laws against it, but there weren't necessary laws defining on how it should be done. In June, and in particular June 17th, 2016, a bill called Bill C-14 passed, and this effectively allowed eligible adult Canadians to now choose an assisted death, provided that they met very specific criteria. Now, not surprisingly, since that time, there has been further debate and further discussion about MAiD legislation in Canada. And one of the other things we hope to discuss with you today is where we're at currently and how our MAiD legislation currently stands after the most recent update in March of this year. Effectively, the bill that came into effect on June 17, 2016, gave capable adult patients who had what we will call a terminal illness, progressive deterioration, and intolerable suffering to seek medical assistance in ending their lives. And this legislation actually put into words the terms under which this process could be accessed and the terms under which it could be provided. Again, another skill testing question. At present, in Canada, the act of administering a lethal dose of medication to a person with a grievous and irremediable medical condition, that's legal speak for terminal disease, for the purposes of ending intolerable suffering, is presently considered homicide under the criminal code. Just give that a thought. You think that's true or false? You may be surprised to learn that that is in fact true. And in fact, every time MAiD is provided, that does in fact constitute homicide. However, there is specific legislation that prevents providers, provided that the process has been followed, from being found culpable. But I was certainly and remain aware of the fact that this is in fact very speaks to, I think, the magnitude of what we're doing here. These were the original eligibility criteria, and I think it's important to review these because many of these are still applicable to our current provision of MAiD. In order to receive medical assistance in dying, the person must be eligible for health services funded by the federal government, and this is really to prevent healthcare tourism, and in particular, assisted death tourism. Some European countries do allow this and have seen an influx of people coming from overseas and coming from out of country to specifically seek these services. And the Canadian government in particular sought to limit this from the outset and restricting it to people who are eligible for healthcare services in Canada. In order to receive MAiD under the original eligibility criteria, the person must be at least 18 years old and mentally capable. So that means they must be able to understand their medical situation and be able to give explicit consent in order to receive medical assistance in dying. The request must be voluntary, and there can be no outside pressure or undue influence. And in order to be eligible, the person must have a grievous and irremediable medical condition. And again, that's legal speak for something that we used to call a terminal condition. That's a bit difficult to understand. And so there's a bit of clarity in terms of what grievous and irremediable actually means. In this case, in the legislation, that condition is defined as someone who has a serious illness, disease, or disability, and is in an advanced state of decline that cannot be reversed, and they're experiencing unbearable physical and mental suffering from the illness, disease, or disability that cannot be relieved under conditions acceptable to the individual, and being at a point where the person's natural death has become reasonably foreseeable. Now, there's a lot of important things in here to unpack, and I just want to spend just a few more seconds going over it. When I assess a patient for medical assistance in dying, I'm very aware of the fact that the definition of unbearable physical or mental suffering is very much dependent on the individual, and no two individuals would necessarily define intolerable suffering the same way. So even though I may have my own constructs in terms of what suffering is, I always go into these discussions and assessments with the understanding that it's the individual's definition of suffering that matters, and it's up to them to define it, not up to me. And it's also important to note that that any interventions that we offer to try to relieve this suffering have to be acceptable to the patient. And so not only is the definition of suffering very much left up to the individual, but we also entrust that individual to describe and tell us under what conditions they're willing to accept ongoing care. Now, the other important thing to take from this is this thing called reasonably foreseeable, and very different to some of the legislations worldwide, and notably in the US, where there's been a specific time frame, and in the US, it's 6 months between when somebody applies and when their natural death is expected to occur. But I think this verbiage was chosen very carefully when this legislation was constructed, because reasonably foreseeable is open to a fair bit of interpretation. But notably, when we try to get a sense as to whether somebody's natural death is reasonably foreseeable, we take into account all of the circumstances around that patient, not just those attributable by the underlying condition. And very importantly, somebody's natural death being reasonably foreseeable does not require us to put a specific time on how much time that person has left. We can get a little bit more clarity in terms of understanding what reasonable foreseeable means, because really, reasonably predictable is another way to look at it. And with experience, factoring in all of the other things that could potentially go into how much longer somebody has to live, and that includes general assessments of frailties. But when somebody's death is reasonably predictable, we take that to mean that it's reasonably foreseeable, and this criteria would be satisfied. Importantly, though, and this is very clearly stressed here, that clinicians should not employ or support rigid time frames. So again, we're not looking to say that somebody's natural death is foreseeable within a set period of time, but rather is reasonably predictable. Not surprisingly, since the initial legislation was passed in 2016, there have been ongoing discussions and in some cases controversies around this process. To give you some examples of some of the controversies that have cropped up, this is, I think, a warning signal for us. And this was a case out of Belgium where a patient was provided with assisted dying in the context of dementia, and they never provided consent for that. And I think that underscores the importance of having a system in place that provides adequate oversight for this process, no matter what that process is. In Canada, and there have also been controversies, and this was a highly publicized case from a few years ago of a patient who felt that she had to choose medical assistance in dying earlier than she otherwise would have because she worried about the risk of losing capacity and not being able to consent to receiving medical assistance in dying. And under the legislation at the time, people who had requested medical assistance in dying, who had gone through the assessment process and were deemed eligible, if they lost capacity between that period of time and the date that they had chosen to receive medical assistance in dying, they would not be eligible as they could not consent to it immediately prior. And so this person was very worried that she was being forced to choose MAiD earlier than she would have liked because she felt she was at risk of losing capacity. We also have to be careful in terms of how our institutions provide access to medical assistance in dying for all Canadians. And this is one case of several that received press over the past several years of a patient who was forced to sign his application form for medical assistance in dying in a bus shelter off the property of his where he was staying, because it was a secular institution, and they did not morally support the provision of medical assistance in dying. With this, of course, and not surprisingly, drew the legal challenges to the legislation as it stood. And most importantly, two people in Quebec, Jean Truchon and Nicole Gladue, both challenged the medical assistance in dying legislation. Mr. Truchon has cerebral palsy and Madame Gladue has post-polio syndrome. Both of these people were very different than the others who had been deemed eligible for MAiD, in that neither had a natural death that was deemed to be reasonably foreseeable. And their reason for wanting to pursue an assisted death was the immense suffering that went along with chronic disability. And we're going to come back to that as we talk about the evolution of MAiD.
Ronald Harper, please report to Colonel 10. Ronald Harper, please report to Colonel 10.
My apologies. And if anybody has seen Ronald Harper, please ask him to return to Colonel 10. In September of 2019, Quebec's Superior Court ruled that the current laws were unconstitutional. And again, Quebec has always been on the cutting edge of challenging this legislation. The government was subsequently given until March 11th, 2020 to propose changes to the existing medical assistance and dying legislation in Canada. And then coronavirus happened. And because of this and subsequent delays, the government then had until February 26, 2021 to pass the legislation. And as we see, we're going to come in right under the deadline for getting that done. Now, the government actually did, I think, a reasonable job at trying to inform the process of what this evolution of medical assistance in dying laws in Canada might look like. And importantly, they engaged the Canadian Council of Academies to talk specifically about things like advanced directives and the ability to put in your will, for example, that if you're ever in a state where you have an illness from which you're not expected to recover, but yet you can't give consent for medical assistance in dying, you're expressing your advance directive to do that, even if you can't consent to it at the time. The issue of mature minors has been brought up, and what to do with people who are not yet 18 years of age and yet still have a very good understanding of their medical condition and have been able to make an informed choice that medical assistance in dying might be for them. And also, folks who have single system psychiatric disease or a psychiatric illness as the sole presentation, also not currently covered in the current legislation, and certainly will be addressed, I think, in the future. There was a national survey of Canadians, and many of you may have actually taken part of this. This happened over a few months between January and February of 2020. And actually, there was very good engagement across the country in terms of trying to survey Canadians in terms of what the general sense was about attitudes towards MAiD across the country. And there are also parliamentary hearings. These are all available in the public record. So if you'd like to go back and read them, it's a fascinating, I think, broad description of the perspectives of medical assistance in dying across Canada from a variety of different groups. And so if you're interested, I certainly direct you to this site to see the vast amount of information that was presented to Parliament as this legislation moved forward. Now, I'm going to pause there and pass it on to Dr. Kane, who's going to take us through our current MAiD laws and how we've evolved based on that information.
Thanks very much, Dr. Parker. I wonder if we can just address some of the questions in the chat. I'm certainly happy to try to address. Some of them are of a similar theme, but I'll start with the first question. This is a question about how to, I guess, assess someone to determine their eligibility to receive MAiD, I think, if I'm understanding this correctly. But basically for now, and I'll talk about future legislation or current legislation in a minute, you can just send them to anybody to do a MAiD assessment. Essentially, you don't have to send them to someone like a pain specialist or a palliative care specialist. You have to do a palliative care referral, but it's a bit nuanced. But the short answer to that very first question is that you send the patient to a MAiD referral service or to a MAiD assessor to determine their eligibility. The second, third, or the third, fourth, and fifth questions are about mature minors and family members asking about MAiD. Basically, the short answer to those questions is that the patient themselves must make the request. And there you would never do an assessment of a patient based on a family member's request for you to do that assessment. It has to come from the patient. And the current legislation, which includes changes made in March of this year, does not include mature minors. It sounds as though the next is more of a comment, and perhaps I will come back to that later and carry on for now. I'm not ignoring you. I'm just going to come back to that later. Is that okay? All right. So, and Chris, Dr. Parker's going to advance the slides for me, so I'm hoping that we sort of sync up, but you could go on to the next slide. Thank you. So in March of this year, on March 17th, the new legislation received royal assent and took into account many of the bits of information from various sources to inform the new criteria. And there was one significant difference. So again, you had to have a serious illness, disease, or disability. You had to be in this reversed or advanced state of decline that can't be reversed, and you had to be suffering. But they took away the reasonably foreseeable death criterion. And that's, they did this because of many of the sort of controversies that arose and many of the concerns with the legislation that it didn't allow people with significant, serious, potentially life-limiting illness, but whose death wasn't quite predictable in that way, not to access MAiD. Some would argue that, in fact, Carter would not have been able to access MAiD with the first iteration of the legislation. You can go to the next slide. So just kind of comparing the two side by side, as of June 2016, the eligibility criteria were that you had to have the grievous and irremediable medical condition, which included at that time a reasonably predictable death. But now they took away that component of it. And they did make very explicit in this legislation that individuals who had a mental disorder as the sole underlying cause of their request for MAiD were excluded. And probably coming down the pipeline in March of 2023, there may be legislation that addresses that. So in terms of safeguards for individuals that met this reasonably foreseeable death criterion, some of those safeguards were eased, but for individuals in the second sort of stream or track of patients, they were actually strengthened. So what kinds of safeguards? Well, we had this 10-day reflection period, otherwise known as sort of a 10 clear days between the written request of a patient and the provision of MAiD. And again, you had to be competent and have capacity to make the decision when you're requesting MAiD during the assessments, and also when you're receiving MAiD at the end of that 10 days. So they got rid of that in the current legislation. They only, or they allowed, rather than 2 independent witnesses, you can just have 1 independent witness now, which makes it easier to provide that formal written request. But for these track 2 patients without a reasonably foreseeable death, there were considerable safeguards put in place, including a 90-day assessment period, which essentially in practical, practically means that a patient starts this 90 days when their first assessment is complete, because it may take longer to really do that assessment, get that person access to support services that they may not have been able to access, and ensure that we're doing our due diligence, and that you cannot waive that 90-day assessment period. It's not specifically for reflection for the patient, but it certainly can be. Again, you have to have 2 independent assessors who can be either an MD or a nurse practitioner, or one of each or both. And if one of those, and this goes to that first question in the Q&A, if one of those assessors is not an expert or does not have expertise in the area of medicine that the person who's making the request has that their illness sort of localized, if you will, then they need to get that expertise. So you don't have to have an assessor who's an expert, but one of the assessors has to consult someone else who is. So as an example, Dr. Parker is a respirologist and critical care physician. I'm a palliative care physician. If we were asked to assess someone in that track 2 who had a motor neuron disease, it would probably behoove us to seek expertise from a neurologist or a nurse practitioner in neurology. And you have to ensure that you consult with support services to make sure that patients are not asking for the wrong reasons. And we'll talk about that a little bit later as well, because it's a bit nuanced. It's not easy to determine whether or not someone's asking for the right reasons for an assisted death. And then finally, the final consent in individuals who have a reasonably foreseeable death, there's the opportunity in this new legislation to have it waived, essentially. And so what that means is that a person who is concerned they might lose capacity in between their initial request for MAiD and MAiD provision can enter into essentially a contract, a written contract between the provider and the patient, indicating that even if they're not clear-headed or clear-minded, when they are wanting to have MAiD, that they can have MAiD anyway. It's important to note that this waiver of final consent, which is what it's called, you can't do that for track 2 patients. They have to be clear on the day of assessment, and they also have to be clear on the day of provision in order to obtain that final consent. You can go to the next slide. So this is that was a very busy slide. So this is just kind of reiterating some of the key highlights of that legislation change in March of this year. The patient must complete a written application that's witnessed by one independent witness. And this witness can be part of the care team, but they can't have any sort of financial interest, or they can't benefit financially from the patient's death. That's what is meant by independent witness in this case. And of course, for people that can't sign, we make provisions for them to articulate their decision. And the disease or disability or serious illness has to be optimized by means deemed acceptable to the patient. That's very important, including access to disability support services. And of course, this last bullet point, I'm very biased, but a palliative care referral should always be offered in the context of any serious or life-limiting illness. It makes sense to offer referral to supports that could improve symptoms and or improve quality of life. Next slide. The patients requesting MAiD are then assessed by 2 independent healthcare providers. And I will stress that in this case, what independent means is that they are independent from one another. So I couldn't, in theory, do an assessment with someone who is my boss or has a position of power over me. They need to be independent from one another. You can talk to the other person doing the assessment and find out their perspectives. That doesn't break any of the rules, and probably you should be doing that. But the 2 assessors need to be able to make as objective an assessment as possible without feeling like they need to be swayed in one direction or the other because of who the other assessor is. We tell the patient about the process, including what they have to do and the ins and outs of the paperwork. Then the assessment is completed to determine if they meet those eligibility criteria. And then that 3rd bullet point is very important. We need to remind the patient of the right to withdraw consent at any time. And I don't know what you do, Dr. Parker or Val, but I always say during my assessment that I'm going to ask them again, and less so if there's a waiver of final consent, but I will always ask them again, right up to and including the moment before the provision, if they consent explicitly to having medications administered that will cause their death. You need to be very explicit. And even if you think, and this has happened to me a few times where people have been angry that I've even asked them again or reminded them that they can change their mind, I say, you know, I have to do this. This is really important part of consent, right? They have to know that they can withdraw it.
Can I just add a point there, Danielle, to that point you were making? I also say that, but I also say me asking you isn't a judgment on your decision to do this. It's me as a requirement within the law to verify, but it's not because I'm judging you in your decision to access MAiD, because sometimes people feel, I think that happens from family, that they're constantly asked, are you sure you want to do this? Are you sure you want to do this? And then they start second guessing themselves. So I put it right out there. That's not the point of this question.
Yeah, that makes a lot of sense. Thank you, Belle.
And could I just build on that as well, Dr. Kane? I think it's very important that, you know, when we go into this, we understand that we're not, our role is not to counsel for or recommend against medical assistance in dying, but rather to guide the patient through that process so that they can arrive at their own decision. And I think we're all very cognizant of that.
Yeah, it's our role is to determine eligibility, to provide the patient with as much information and support that they need to make a decision. But, you know, and I say this as well to my patients, you know, many of whom I know from being a palliative care provider, that I will support you no matter what. But if this is a decision you want to make at the very end of your life, then that's your decision to make. I think we can go to the next slide, Dr. Parker. So just outlining the safeguards again, the witness, well, there's only one now instead of witnesses, and healthcare providers must be independent. And there's no longer this mandatory clear period of 10 days, which was, you know, I can speak to having done this since 2016, which was extremely distressing for some patients who didn't end up having MAiD or worried that they were not going to make it, withheld medications that they thought might, although make them more comfortable, make them less able to consent. So that particular element of the legislation that was changed was very important for a lot of people. And then, of course, again, we have that 90-day assessment period in place for patients whose death is not reasonably foreseeable. Next slide. So just a little bit about the logistics of providing MAiD. And I also explain to patients what this looks like too, because it's one thing to talk about it in abstraction, and it's another thing to really talk about what it might be like in that room that day. And again, I think it is important for us as assessors to ensure they have as much information as possible about this process, as much information as possible about alternatives, which I do talk about, which we all talk about. So if the patient has a reasonably foreseeable death, but they did not sign a waiver of consent, and they become delirious, which happens, or very confused at end of life, which happens in many patients as they approach end of life, they will not be able to have assisted dying. Having a reasonably foreseeable death alone does not allow you to waive consent. It has to be a very specific written contract between provider and patient. Patients do have the ability to self-administer oral medications, but I have to tell you that in Ontario, since this has been legal, out of the thousands of patients that have had an assisted death, only 2 have self-administered. This is for a variety of reasons, one of which is that, logistically speaking, it's been difficult to acquire some of the medications needed for the oral self-administration. And the second reason, and I think this resonates with me a little bit more, is that the risk of complications, of things not working, of things taking time, of suffering is higher when people self-administer. So, you know, if I were to counsel a patient who was trying to decide between those 2 options, I would certainly advise or speak to the fact that physician-administered assisted dying has a much lower rate of complications. You know, we only have one chance of getting this right for patients. That's my perspective anyway. Next slide. For those who are curious, the medications that we use are delivered intravenously. You have to make sure you have reliable IV access, and in patients for whom reliable IV access is not guaranteed, Often those patients are sent to have a PICC line inserted so that we can guarantee that they have intravenous access. The first medication given is usually midazolam, which is a type of medication that causes people to sort of deeply relax and sedates them. We give opioids or narcotics if they have pain, but it's not part of the toolkit, so to speak. You don't have to give it. And then we use an anesthetic, which is propofol, and then a medication that stops breathing, which is rocuronium, and stops the heart, which is bupivacaine. And death is declared after 10 minutes. And importantly for patients and families, and you may be asked questions about this now or in the future, you don't write on the medical certificate of death that they had assisted dying. You write the underlying condition. And in fact, insurance companies can't withhold insurance. They can't ask about this. And I have had patients say to me, well, I would have considered this, but I thought it wasn't an option because I didn't want my wife and children to not have my insurance. So again, you know, sometimes it feels like you're giving them so much information, but it's really important to ensure that they're informed. This is literally a life or death decision, right? So they really need all the information you can offer in order to make the choice that's right for them. Next slide. So again, going back to mandatory oversight, which, you know, thank goodness we have to have this. There are vulnerable populations and we need to ensure that we're protecting them as best we can. In large part, provincial authorities are charged with providing oversight for MAiD, and in Ontario, it's the Office of the Chief Coroner. After each MAiD death, Dr. Parker and I have to call the coroner and give a detailed outline of the patient and their medical history and the medications given, etc. There's also a mandatory federal reporting system that is not super new, but it's pretty new. Like I think November 2020, something like that. Chris? Yeah, okay. And they, sorry, go ahead, Val.
2018.
2018, okay. I don't even know what's happened. It's been a
time flies.
So there's mandatory federal reporting now of all MAiD cases. So that includes people that get referred that are never assessed. That includes people who are referred and have one assessment. That includes people who are referred, have two assessments, and then are denied. And that also includes people who have MAiD provided. And there's guidance for how you report on it on the Government of Canada website. Next slide. Okay, so this is where I'm going to pause, and I'm just going to open the Q&A a little bit. So the goal of consultation by an individual is expertise, understanding that can show. Well, that's a very good question. So is the goal of consultation by an individual with expertise just for understanding better that condition, or are they to give an opinion or advice regarding the patient in question? You know, I have only ever asked for consultative expertise once, and maybe Val and Dr. Parker can speak to this as well. But I actually asked for both. I wanted to make sure I understood to the best of my abilities their underlying medical condition. And then I would ask what they thought about this particular patient and whether or not, you know, in their opinion, they would meet eligibility criteria. Am I comfortable to provide MAiD? Oh, it's a loaded question. It is very hard to provide MAiD. And I have always said that the moment that it doesn't feel hard is the moment I will stop doing anything, having anything to do with it, anything to do with assessments or provisions, because you're in the face of suffering, right? So yes, I am comfortable in the sense that I am comfortable with it from an ethical and moral perspective. If I think it's the right decision for my patient and they've made that decision, I don't have qualms about that. But I find it still distressing. And I think we're going to talk a little bit later about burnout among MAiD assessors and providers. Why the difference concerning final consent between the two streams? You know what? I don't know. And maybe I'll just go through the remaining questions, and then maybe Val or Dr. Parker can answer that one, because I don't know. The compensation model for MAiD providers and assessors. Val will certainly speak to that from a nurse practitioner perspective. So we are remunerated using the same billing codes that we would do for a regular consult or assessment in our specific discipline, from an MD perspective. And nurse practitioners, I will leave it mainly to Val, but suffice it to say they're not remunerated well / at all at the moment in Ontario. What is the relative proportion of MAiD assessments or track 1 and new track 2 in the last few months? So we will get to that. There's a slide that specifically addresses that one, Dr. Eisenhower. And I think it's in Val's section. Okay. Do either of you want to answer the question about the difference with final consent between the two streams?
So I believe it stems from the waiver was put in place to address the loss of capacity for patients who are nearing the end of life. And so hypothetically, you wouldn't expect someone whose natural death is reasonably foreseeable to lose capacity to give that final consent. And if they did lose that capacity, then they likely would move to track 1 anyway. Yeah. So there, you had mentioned, Danielle, that the 90 days can't be shortened, and it technically can't, but the patient can move from a track 2 to a track 1 if something changes in their medical picture that would deem their natural death reasonably foreseeable. So it was meant to address that for those patients and for that reason.
Yeah, that makes complete sense. Dr. Parker, did you have anything to add? Okay, so I will pass the torch then to you, Val.
Okay, thank you. So I'm going to pick up on the reporting and sort of the oversight that we've had. And since November 2018, we have been collecting these stats through Health Canada, through the portal, on those patients who have died from MAiD, and then also those who have been assessed and have not received MAiD for whatever reason. And so in July of this year, we had our second annual report, which can be found online. And it's actually worth looking at because there's the first bullet when you open the website is highlights, and it pretty much tells you everything that you need to know about what's going on. And interestingly, the first annual report and the second annual report were very similar in their findings. Next slide. So since legalization in June of 2016, there have been an increasing number, as you can see, of deaths by medical assistants in dying across the country. And as of December 31st, 2020, which is the end of when we have data nationally, there have been over 21,589 Canadians. That number isn't exact because some of the patients, like Dr. Parker mentioned, who had MAiD in that interim period between February and June of 2016 aren't captured in there, but suffice it to say, there are a number of Canadians who have made this choice, and increasingly more each year. And then this shows by province the breakdown, and it's quite similar across 2020, and if you were to look at the 2019 data, and you'll see that the average is 2.5% of all deaths in Canada are attributable to medical assistance in dying. And they vary between 0.9% in Newfoundland up to 4% in British Columbia, which isn't surprising, given that the first MAiD case that Dr. Parker spoke about was in BC. They were very ready to start doing this. 94.7% of all of those provisions were done by MDs, meaning that there was very small percentage done by nurse practitioners, and we'll see the Ontario specific data for that. But knowing that the remuneration for MAiD work in Ontario specifically and in many other provinces has a big impact on the number of nurse practitioners who are participating in it, clearly puts the bulk of the work on our physician colleagues. And then by comparison, as Dr. Parker mentioned, sort of the Benelux countries being some of the earliest adopters to medical assistance in dying, their rate is about 4.6%. And then the United States, in those few permitted states, is about 0.3%. And I think it's important to recognize too that in the Benelux countries, they have a different method of administering assisted dying compared to Canada, compared to the US. So it's a little bit different. It's not necessarily, it's more like varieties of apple comparison than apples to oranges or apples to apples. Next slide, please. So who has chosen MAiD? So these bar graphs show you the last 2 years. So you can see that they're quite similar. And by age and category, it's around the 75 years of age is the average age, and pretty much equal men to women who choose this. And then as far as what the underlying diagnosis is, cancer being by far the most common underlying diagnosis for those who choose medical assistance in dying, and then cardiovascular, respiratory, and neurological in close succession, very equally distributed. The smaller bar graph shows the proportion of where MAiD has occurred. So MAiD can occur in any location. We have had some cases, many of obviously are in hospital and home, and in 2020 more so in home because of the pandemic. But there have been other interesting cases in other parts of the country that have been done outside, in public parks, in funeral homes, which is becoming sort of the newest thing in medical assistance in dying, where funeral homes are turning their sort of casket showrooms into provision rooms, because many people have various reasons why they don't want to have this procedure at home or don't want to die at home from any cause. And definitely don't want to be in hospital. And so finding a third-party location has become something that many people are working towards. There's actually a place in Toronto called MAiD House, which they're hoping to expand to other larger cities and areas across the country that would provide this third-party location. And just to note on the bottom there that from the data in the 2020 report, 82.8% of MAiD recipients also received palliative care. I will say that it's difficult to answer that question at times because we don't know the quality or from whom the palliative care is coming. So I think knowing that the answer is they receive some sort of symptom management is reassuring. And then 90% of MAiD recipients also who require disability supports also received them. So it seems as though from this data that our patients are very well supported in making this decision from an educated perspective. So here's the latest Ontario data, and we get this monthly. It helps to keep us up to date on sort of the nuances and the patterns within MAiD. So you can see the total number of cases completed in Ontario since legalization is almost 9,000. And in September, there were 322 cases. And in the year total, so the first 9 months of the year, there were 2,197. And of those, as Dr. Kane mentioned, the vast majority were clinician administered. Of those 2 patient administered, the first one was right at the beginning of legalization and it did not go well. I believe it actually had to be transferred into an IV administered death because the medication didn't work as it was supposed to. And then the second one was actually done in a hospital quite far up north where there were limited access to providers. And the hospital acquired the oral medication for the patients to self-administer while in hospital. And then an interesting subset of medical assistance in dying is its relation to organ donation. And there are protocols and papers discussing specifically organ donation after medical assistance in dying. And that is becoming a much more studied, and sort of barriers are being pushed in real time in regards to where deaths from MAiD can happen in order for organs to be donated. So it's definitely up and coming. And so far we've had 65 successful donations within Ontario from MAiD deaths. And here, this page speaks to the providers for MAiD and some of the demographics around them. So as we talked about, federally, the proportion of physicians to nurse practitioners as providers is reflected in the Ontario data as well. And so I'll speak specifically to Ontario. Nurse practitioners in this province are only paid for medical assistance in dying work if it is done within their employed work. So I get paid to do MAiD assessments within my role with home and community care support services as a palliative care nurse practitioner. But for example, a colleague who works in primary care who has a full clinic day, but would like to see a patient to do a MAiD assessment after hours would not be remunerated for that assessment. So it definitely limits the number of nurse practitioners who are willing to do MAiD work. It's quite, as Dr. Kane and Dr. Parker have discussed, emotionally difficult, challenging work, and deserves to be remunerated and paid for appropriately. There have been some nurse practitioners across Ontario who have done this work for free. One nurse practitioner has done hundreds of provisions without being paid. And that speaks to the passion that this NP has for this work, and that she does not want to leave patients in the lurch, because that's the reality. So we're definitely doing as much as we can at this point to get the Ontario government on board with providing some sort of billing ability for nurse practitioners to do this work. And this would definitely address some of the access issues, because there are pockets of this province and across the country where MAiD assessment access is limited, for sure. And then you can see the breakdown by specialty, and this would be for physicians only, that the vast majority, 2/3 of physicians who participate in MAiD as providers have a family medicine specialty. But there are a number of other specialties as well that are represented. And then Dr. Eisenhower asked a question about the track 1 versus track 2. So this is since March of 18th, 2021, that there have been 1,672 track 1 MAiD cases have proceeded to MAiD, and 23 track 2 patients. Here in the Southeast, we have a regional coordination service, which we'll speak to a little bit more in regards to accessing MAiD. But this is just a graph to show you sort of the average number of referrals that we get on a monthly basis. And sometimes the calls that we get are just requests for information, but most often they're for requests for either initial or secondary assessment. And luckily we have a fairly robust pool to tap from in regards to assessors and providers within the community, which means our turnaround for getting a patient lined up with an assessor or provider is within the first few days after receiving a call. So why do patients choose MAiD? I think this is a really important question to consider, and something that I think, regardless of your role within the healthcare team, is something to be aware of. Many people, I think, assume that people choose MAiD based on physical symptoms or inappropriate or unwell managed symptoms. And the reality is that a lot of the requests stem from loss of control, loss of independence, feeling like they're a burden on the people around them for that care that they required, the loss of ability to do things that brought meaning and joy to their life at one point, and a fear of future suffering. And this data shown on this slide comes from a paper put out by Ellen Weeb, who's sort of a guru in MAiD in BC, but it's from 2018. And we know that from the data in the first 2 annual reports that actually the loss of control and independence and loss of enjoyment in daily living are right up there in the 80% of patients who request medical assistance in dying, whereas physical symptoms tend to be reported by more closer to 50%, 50 to 60% of patients. So it really is that sort of existential suffering that draws people to medical assistance in dying rather than the physical side. So we do have some data on those who didn't receive MAiD, even though they applied, and this data comes from Health Canada. So as Dr. Kane mentioned, whenever there is a MAiD death in Ontario, the provider is required to speak with the coroner's office to one of their nurse investigators. When patients don't receive MAiD, it is the responsibility of the person who either did the assessment or transferred the patient's request to somewhere to go into the Health Canada portal and report on that death. So This likely doesn't capture all of the requests that came through because many people don't realize they have that responsibility. But for 2020, the portal reported on 9,375 requests for MAiD. And of those, 78.8% received MAiD, whereas 21.2% did not receive MAiD. And so of those 21.2%, there were a variety of reasons. So 6% of these were deemed not eligible for MAiD. 2.5% of these patients withdrew their request, so decided that MAiD was not something they wanted. And the vast majority of them died while awaiting MAiD. So I think this speaks a lot to the fact that we were requiring patients to wait that 10 days at this point. This was before the new legislation. So there were individuals who were who happened to die during that waiting period. As well, I think it speaks to the fact that oftentimes MAiD isn't brought up in a timely enough manner for people to complete the assessment process and do the sort of what I call bureaucratic red tape paperwork of MAiD before they really actually want this as an option. And so then we're left sort of chasing our tails and trying to get things done quickly. And oftentimes that means the patient doesn't achieve the goal for them, which is receiving MAiD. So I will pause there for questions. I'll have a look in the Q&A.
Val, there's a couple, I've been trying to answer some of them in the chat. There's another couple that you may be best suited to answer in the Q&A.
So the number of MAiD patients per year or cumulative, I guess I'm not sure which slide you're speaking to, but the one with the bar graphs is each year. It got bigger and then the cumulative number was over 21,000. And then in Ontario, there are all of those numbers. So there's since legalization, in the year total, and in the month. In our hospital and region, are there sufficient numbers of comfortable and trained assessors and providers to handle requests from patients? No. I ask, since Dr. Kane pointed out, this is very hard, and I imagine there's an upper limit on numbers of cases and individuals can manage while maintaining their emotional equilibrium. Yes, the answer is no, and that is not unique to the Southeast. So I sit on the Dying with Dignity Clinician Advisory Council and the Provincial and Territorial Advisory Council for CAMAP, so have a bit more of a national picture. And there are concerns about numbers of providers and assessors across the country, more so since the legislation changed with the addition of the Track 2 patients, which take more time, more hours to review. The cases are more complicated. They're not as straightforward as a patient with end-stage cancer who's at the end of their life. And that can create a lot of concern, both from a time management perspective, but also from a moral distress perspective. I know the Track 2 patients that I have assessed have been very challenging, almost more so than the Track 1 patients, I guess, because I deal with dying patients every day. And that part isn't as hard for me, but seeing the struggle that patients who fall under Track 2 have with the healthcare system and the multiple visits, multiple providers, social concerns that they have has been hard for me. And I think it's only going to get worse once mental health as a sole underlying diagnosis becomes law. So, and we'll talk a little bit about the fact that there's no requirement if you want to do MAiD work that you do all of those types of MAiD cases, but there definitely is a need for more. The responsibilities of a nurse during MAiD have changed significantly over the years. How do you see this role progressing, specifically concerning RNs and RPNs? So I guess I see that differently. In my experience, the nurse's role in MAiD is supporting the patient in their decision and supporting the family in their decision. They don't have a role as far as speaking to eligibility. I think there is more comfort perhaps in society in general in talking about MAiD and sort of being able to have those conversations. And I think that is applicable to any specialty, not just nurses, but any healthcare provider could be the person that a patient discloses their interest in MAiD to. nurses definitely have a role as far as intravenous insertion and being there to support during the provision. But I think that nurses are present for many hard interventions and procedures that are done with patients and families. And I think the same emotional support that's required during those is required during MAiD, same as at the end of life, being present with someone and bearing witness. We're going to speak to the last two questions as our slides progress, so I'm going to hold it there. Backtracked on me. Okay, so whose job is providing MAiD? So as I've alluded to, there are many Canadians who still don't know that MAiD is a legal option or how MAiD fits into the medical landscape. And that would include healthcare providers. And that's why we're so grateful that you're all here today learning about this, because I think one of the most important pieces of advice that I can give is to prepare yourself for when this is going to come up with a patient or a family member or a friend. We're all going to die. We're all going to support people both personally and professionally who are at the end of life or who are suffering intolerably. So preparing yourself for how you're going to react is really important. Dr. Kane spoke to the idea of misperceptions in regards to things that may prevent somebody from accessing MAiD. So the idea that it's akin to suicide or that it will be listed on the death certificate. So clarifying those misperceptions is important. And really highlighting the fact that MAiD is not for everybody and not even for most people. And we can see that reflected in the data, right? Only 2.5% of all the deaths in Canada were from medical assistance in dying. So it is a small percentage of people that make this decision, but people have a right and they deserve to know all of their options. And we ensure that that's the case in any other medical setting where we're providing treatment options to patients, that we don't withhold one or two because we don't necessarily think they're going to be in the patient's best interest, right? We allow the patient to make that decision. So conscientious objection is written into the MAiD law, and we really understand that MAiD is not for everybody from a patient perspective and an assessor provider perspective or as a support person perspective. That people are allowed to decide how much they want to be involved in MAiD. So I talk about it as being on a spectrum. So being a conscientious objector means you don't want anything to do with discussing MAiD or being a part of the MAiD process for whatever reason. And on the other end of the spectrum is somebody who is willing to provide, to discuss, to educate, and to walk with a patient through that journey. And then there's everything in between. So figuring out beforehand where you fall on that spectrum is important so that you can respond in a respectful way when a patient makes a request or a statement that you think might lead to a discussion about MAiD. And specifically within policies within the CPSO and the CNO, they have statements about conscientious objection. So it's important, I think, for everybody to look at what their college has to say about your role in medical assistance in dying and whether they make a statement about that so that you know that you're fulfilling your obligations to your patient. And basically it means that you can't abandon your patient. You don't have to participate in MAiD, but that you must make an effective referral, specifically for nurse practitioners and physicians, to somebody who is able to provide that support for that patient. And then you can continue on in your involvement with that patient for whatever reason that you were involved in the first place. So perhaps as a primary care provider, you would continue to provide primary care to that individual, but you would refer them for their request for MAiD. Dr. Parker, did you want to add something?
No, thanks, Val. I was just going to say we should highlight there's some subtle differences, I think, between the CPSO policy and the CNO policy that you're going to speak to in a second. But and notably for physicians, even though you may be a conscientious objector and the legislation respects that, again, MAiD is not for everyone, be it a patient or be it a healthcare practitioner. But physicians do have an obligation as set forth by the college to make sure that patients' requests for information around MAiD, and in particular requests for assessment around MAiD, are met. And you can convey to the patient that you have a moral objection to MAiD, and this is why you're referring them on, but you can't abandon them, and you cannot refuse to talk about it even though you morally object. But Val, I think there's a subtle difference there between the CPSO policy that we're looking at now and the CNO policy illustrated here.
Yeah, so interestingly, they basically say the opposite, that for physicians, you must explain that you're a conscientious objector, and for nurses, you must not explain that you're a conscientious objector. I don't think it really matters in the grand scheme of things, as long as you're respectful. But again, that goes back to the idea of preparing yourself for when you're in this situation and not sort of speaking without thinking, which I think could be detrimental to the therapeutic relationship if it needs to continue. And then we talked a little bit about the idea of institutions being conscientious objectors, and that's a very contentious issue. There's a question in the Q&A regarding that, and this is again a national issue. And some provinces, some institutions with a religious affiliation have done a better job of sort of extending the olive branch and meeting in the middle in regards to this, and others have not. So there are some institutions like Providence Care Hospital that don't allow MAiD to proceed on site and will have patients transferred for assessments and provisions off site. There are some Catholic institutions like St. Martha's, in Nova Scotia, who have created a sort of secular room within their institution where MAiD can proceed by people coming into the institution who are not employees of St. Martha's. So there have been some workarounds, and there are definitely lobbying still being done by organizations like Dying with Dignity Canada to stop federal or provincial funding for these institutions if they are blocking access to medical assistance in dying. So there's work to be done there. Chris, do you want to take over?
Sure, yeah. So, again, I think we recognize that there is that spectrum of conscientious objection. For patients, it's easy. If you're a patient who conscientiously objects, MAiD is not for you and don't apply. For practitioners, be they physicians or nurse practitioners, there are certainly provisions, and be aware of the policies. And Val, thanks for mentioning that the institutions, I think it's still a bit of a gray zone. What are our experiences of healthcare providers? And this is, I think, important because as we've heard several points through this presentation, this is emotionally charged work. It's hard work. And I think in order to make it sustainable, it's very useful to go and poll the people who are doing it and find out what their experiences are. This has been done in several forums, and we just present a snapshot of some of the data that we have. But when you evaluate the data of healthcare providers who are involved in the MAiD process, there are certain themes that emerge. And one of the most important themes that we find is that MAiD is felt to be rewarding work by those people who do it. Especially, as Val mentioned, when the remuneration is not monetary, but this is passion behind helping others who are choosing this as their option. This is a study published in Canadian Family Physician a few years ago, but just some narrative experiences from healthcare providers, and you can see some of the experiences they've had. And most of these folks, I think, really convey not only a sense of the powerfulness of the act itself, but also the appreciation that they feel from the patients. This is another statement commenting on to be able to fulfill someone's dying wish, to be able to offer someone a comfortable death that would end their intense suffering is an honor and a responsibility. And one participant explained that being able to give someone this gift, people are incredibly thankful. And I certainly would echo the fact that at times it can be a bit overwhelming. And certainly the emotion that's present sometimes in the room can be quite awesome. Another participant noted that the work is so wonderful to be able to offer these folks something that they really, really want and deserve and have the right to, and they're very grateful. And certainly this is my experience as well. And I'd welcome Danielle and Val to speak to this as well.
I actually just wanted to answer, there's one question in the chat that I think I could give a quite a succinct answer to. If time allows, could you comment on how you usually bring up the topic of MAiD with patients? So I have my own sort of spiel. So if I think that a patient is alluding to MAiD, but I'm not sure, I will usually say something along the lines of, since MAiD became legal in Canada in 2016, many patients with your condition, fill in the blank, have had questions about assisted dying. And I wanted to let you know, if you had questions or wanted more information, this is a safe space in which to ask them. And I frame it like that so that it doesn't feel as though I'm suggesting it or recommending it. I want them to know that they can ask about it and they can talk to me about it, and that, there wouldn't be any judgment. But I also, on the small chance that I'm wrong and they weren't referring to that at all, I also don't want to be seen as, having an agenda. So that's what I say, Julia. Thanks for your question.
I would add too that Danielle and I are sort of in unique situations as palliative care practitioners, and for me even more so, because I generally see patients who are quite far along in their end of life experience, and so functionally and high level they meet MAiD eligibility criteria. So for me, I ask every single one of my patients whether they've ever wanted more information or had questions about medical assistance in dying, usually within the first 30 minutes of meeting them. During my initial assessment. And that stems from an experience where I didn't bring up MAiD at the very beginning when MAiD was legalized, and it resulted in a patient worrying and stressing by himself, not knowing that he could talk with me about this, and then having to rush through a provision assessment process and provision because he was losing capacity. So I think it really depends on the setting in which you work. And the relationship that you have or will have with that patient, and how appropriate it is to bring up MAiD as an option. But I definitely agree with Dr. Kane and reading into or listening to what's not being said in the comments that are being made.
I wonder if either of you wants to comment on Dr. Gugliotta's question about existential suffering?
Yeah, it's an excellent question. And I think when we're trying to assess somebody's suffering, again, we very much keep in mind that, it's that person's construct of suffering, and it's their definition of it. Many times when we're looking for help to try to understand that person's suffering, it's often with the intent to try to alleviate it or relieve it. And so I don't think there's necessarily a set go-to that I use, to try to address that. It very much depends on the person. Sometimes spiritual health can be very useful. And in other cases, the person is very introspective and inward and doesn't find that to be useful. So I'm not sure there's a set algorithm that could be applied. Other than to keep in mind that existential suffering, that fear of loss of independence, that fear of future suffering, that fear of, the uncertainty, that very much is what drives people. And I think, at least in the track 1, patients contributes very much to why they choose me.
I think too, I'll add to that, Dr. Parker, I missed the opportunity to speak to it as well in regards to that percentage of patients who die without having MAiD, right? We talked about the fact that patients can withdraw their request for MAiD and have the opportunity to not go forward with MAiD. And I know for a number of my patients who I assessed for MAiD, and likely you guys have the same experience, that the therapeutic benefit of going through a MAiD assessment often allows people to live out their natural life, knowing that if things get too bad, that they have MAiD as an option. And I find that anxiolytic effect of going through a sort of life review and discussing some of those existential concerns and answering some of their questions about what is this going to be like if I don't have MAiD, can do a lot to ameliorate some of those concerns and allow the individual to move forward and die a natural death while having MAiD sort of there in their back pocket.
The other question that came up is around provisions in legislation in either college around providers to be in touch with family members after the medically assisted death, and is there research in this area? I think one of the key tenets of this legislation in this process is that the decision to pursue MAiD can only come from the individual. There are certainly cases where there is discord between the person who is requesting a medically assisted death and their family. And part of the role, I think, of the assessors and the rest of the healthcare team is to try as best we can to, reconcile those differences. But ultimately, the decision to pursue medically assisted dying lies with the person. I have been involved in some cases, which fortunately are in the vast minority, where there has been that discord. And it is, I think, left a sour note in the taste of the family members left behind. But ultimately, that's something that needs to be worked out with the patient and their family. And we listen to the patient.
I think too, for me, when there's sort of some evidence within the assessment process, so I often encourage family to be present during the assessment. I will ask them to step out for a period of time to ensure that there's no coercion. And I ask the patient some questions about, what does your family think about your choice? And does that matter to you that they support you? And what would they do if you changed your mind? And then I ask the family to come back in and I ask those same questions of the family members. And that exchange of being able to hear how that family feels about the patient's desire is incredible. It is one of the most emotional parts of the assessment for me. And I value being able to give that gift to those individuals in the room. And when there have been concerns about family not being supportive or family who have chosen not to be present during the assessment, that's often a red flag to me to ask some more questions. Are there unfinished things within this relationship that maybe we need to try to tie up? Or, how can I help you to cope a little bit easier with the fact that your family isn't supportive or a certain family member isn't supportive? And it doesn't always end in a tied, neat little bow at the end. Often there are concerns and struggles with family not supporting. But I think even just having that open space to talk about that, and that this is hard and that it hurts that people aren't supportive, is really important for people involved.
Val, could I just follow up? I'm afraid I misunderstood the earlier question about college legislation around touching base with the family. Very much, I think family members at the person's discretion, obviously, are certainly welcome in the room if that's what the patient requests. And so there is that experience that is realized by those folks in the room. Part of, I think, the role of the provider is to do a bit of a debrief after with the family. And importantly, too, at least in Ontario, that the Office of the Chief Coroner will follow up with the family after every case to see if there's any specific concerns or any specific issues that the family wish to raise. So I think that's a very valuable point. This is a novel experience most times for the family member as well. And I think there is that obligation to try as best we can to help them through the process. So I apologize for not understanding the question earlier.
Yeah, I would say that there's also emerging evidence that the grief and bereavement process that family members experience after a MAiD death is unique. And we need to therefore figure out unique ways to support them. I mean, from a palliative care perspective, the family or loved ones are always the unit of care. So, in the thankfully very few situations when there's been a lot of distress and discord because a patient is choosing MAiD, I tend to spend more time doing more visits, trying to do, legacy work, referring to social work or counseling or psychosocial oncology or whatever the case may be to help those individuals. But as Val said, it's not always tied up with a nice little bow. But I think, you know, part of our job is to support everyone involved. And, you know, part of the work in palliative care is to do help with grief work, which starts sometimes before the death of a loved one, right? Anticipatory grief. So I think we have work to do in those areas, certainly.
I'm just keeping an eye on the time here as well. Just looking at the future and some thoughts as to what MAiD may evolve into in the future. And this has come up, I think, at a few points in the presentation, but the issue of advanced directives for MAiD, I think in the survey of Canadians, this was one of the areas that many Canadians identified as something they would like to see MAiD legislation evolve to include. The issue of mature minors is still sorted out, to be sorted out rather, and that's a work in progress. And then mental disorder is a sole underlying cause. And I believe the government has about 18 months left to try to get their heads wrapped around what exactly they're going to do with some of these future considerations. Damn, almost 6 o'clock.
Should we just put up the slides about the locally, how to access? Oh yeah, I'll speak to
the question was raised in the chat earlier, just about some support, and I would certainly recommend anybody who's interested in this topic, and certainly anybody who is considering taking a more active role in assessing and providing, or even if you just want to educate yourself on the process. The CAMAP website is an excellent resource for I think everybody who wants more information about MAiD. Val, do you want to speak to the NMC development project?
Yeah, so there's a working group that's been funded through Health Canada through CAMAP to come up with a national MAiD curriculum development project. So there's multiple working groups that are focusing on different modules that will be available within the next 4 years for MAiD training and education. And the hope is to be able to eventually incorporate that training into medical and nursing school curriculum so that there's some familiarity with MAiD right from graduation. So I kind of mentioned this before. Sorry, go ahead, Chris.
Oh no, just this is how we can access MAiD services in Ontario and in particular in our region. There is an Ontario MAiD care coordination service, which ultimately would funnel through our regional coordination service, which you can access locally as well. For patients who are affiliated with KHSC or who are at Providence Care, there are specific internal policies and ways to reference or rather access MAiD services for inpatients as well. We'll skip over this stuff here. We also have some resources that will make the appropriate arrangements to get to all participants today. And lastly, we do again recognize the sensitive content of what we've presented, and hopefully we've been able to do a reasonable job of keeping this objective and stress that MAiD is not going to be for everybody, and we do recognize that that there may be some need for debrief after this session.
So let me jump in now because we're just at 6 o'clock exactly. I cannot thank you enough for this wonderful talk, which I learned so much about a very complex topic. You clearly identified that there are so many multiple components to approaching this topic and approaching the care that you're providing. I really appreciated that you were sensitive to the challenges that the patients and the families experience, as well as the healthcare providers, and that I really admired and appreciate that you said be prepared for being asked these questions in future, because that's really the point for this session, so that we're well informed and we can think and reflect upon your teaching. I sincerely thank you all for your work and for your contribution to this important topic. Thank you so much. I'll say good night for now.